Another thing that we could look at, since this was a longitudinal sample, was we could look at how many children kept their social phobia diagnosis. And so what this is showing is just the percent among, I should say that what I've shown you up until now has been lifetime diagnoses. But now we're talking about current diagnoses. If you take the children who had a current diagnosis of social phobia at the first wave and ask how many of them still have a current diagnosis of social phobia at the second wave, although it's a small group of children, what you find is that the percent still affected was 64%, which is pretty high stability over 5 years, or pretty high recurrence over 5 years. And that high rate was found even in young kids, even in kids under 7. The number of children who had social phobia was too small to do analyses predicting stability, but in the sample as a whole, we could look at what factors predicted persistence of any anxiety disorder from baseline to 5-year follow-up, and this analysis is actually in kids 12 and under. And what we found was that younger age of child predicted greater persistence. So if a child's younger and has an anxiety disorder, it looked like it was more likely to last. And we also looked at psychosocial adversity factors. These are factors identified by Michael Rutter as general factors for increasing the risk of psychopathology in children. And they're things like low SES, large SIB size, high family conflict, exposure to paternal antisocial behavior, exposure to maternal psychopathology. And any one of these risk factors alone doesn't really confer much added risk, but as you start to add them up, the child has higher risk for psychopathology. And what we found was that there were significantly higher number of these factors in the children whose anxiety persisted than in the children whose anxiety did not persist. Okay, and the third predictor was temperamental characteristics, which I'll talk about in a moment. So now for those of you who were here yesterday, I know you heard a lot about behavioral inhibition, so I'll just summarize a little bit in case anyone wasn't there. Behavioral inhibition is a consistent tendency to show marked behavioral restraint or fearfulness with unfamiliar people, situations, or events. And it's estimated to occur in about 10 to 15% of children. It's evident in toddlerhood or earlier, and it's moderately stable. We discussed this a lot yesterday, but it's moderately stable throughout childhood, and the most extremely inhibited children tend to stay the most inhibited. It has a higher heritability than social anxiety. The heritability is estimated at 0.5 to 0.7 in toddlerhood, even higher for kids extreme in inhibition. And it looks different at different developmental stages because of maturation. And I was hoping that Nathan Fox would have been able to show his films yesterday, because I think you would have had a better sense, but I can just describe verbally. The 2-year-olds tend to show overt distress. When they come into a new situation, they fret or cry. They stay close to their mother. They cease vocalization. They show a lot of hesitancy to approach new peers or new toys or new strangers, and they tend to withdraw as well. By 4 to 5 years, you don't see as much overt distress or crying or clinging, but you see the children being very quiet and affectively subdued with unfamiliar adults and peers. They hesitate to play with unfamiliar peers. They have long latencies. They take a long time to speak spontaneously to unfamiliar adults. And by age 7, you see these kinds of behaviors more in a group setting with unfamiliar peers. The physiologic markers include high and stable heart rate, higher salivary cortisol, evidence of increased right frontal EEG activation, but not all studies find these physiologic markers, and people tend to define behavioral inhibition behaviorally. Dr. Fox talked about this in great detail, but it appears to be rooted in a lower threshold to amygdala and sympathetic nervous system arousal in response to novelty. One other point to make about this is that it doesn't just occur in people, that behavioral inhibition or behaviors like it with similar physiology occur in a wide range of animal species, leading people to hypothesize that this is an evolutionarily conserved fear response to novelty. So we see withdrawal, inhibition of behavior, and freezing in species like fish and mice and dogs and non-human primates. And for example, in monkeys, the temperamental fearfulness that looks phenotypically like behavioral inhibition also is heritable, also goes with right frontal EEG activation with elevated cortisol, and is mediated by the amygdala. So what are the associations between behavioral inhibition and social anxiety disorder? Well, pilot work by our group had suggested that BI might be a risk factor for anxiety disorders in general. And so there's kind of a question, is BI a specific risk factor for social phobia? And actually it's interesting how this pilot work originally started between Jerry Rosenbaum and Joe Biederman and Jerry Kagan. It really started with a dialogue between psychiatrists and developmentalists, because Jerry Kagan came to MGH and did a grand rounds and talked about this cohort of little inhibited children that stayed stably inhibited, that he was following, that were quiet and subdued. And they sounded to Jerry Rosenbaum, who's a psychiatrist treating adults with panic disorder, like the childhood histories he was hearing about from his adult panic patients. And so he got Joe Biederman, who's a specialist in studying child psychiatry. They approached Jerry Kagan, and there was this window when Jerry Kagan's lab wasn't being used over a summer, and he said, if you send us some offspring of patients, we'll look at them. They obviously, you can't take a panic patient and go back to their own history, but you can assume that kids look like their parents, and so they got together this very quick, somewhat dirty sample of offspring of parents with panic, with agoraphobia, with panic, with depression, and they had some psychiatric controls who really were the siblings of children Joe Biederman had been treating for ADHD. And what you see here, I'm just showing you the number of spontaneous comments, because inhibited children make fewer spontaneous comments, and what you see is there are significantly fewer comments in the offspring of parents with panic, with or without depression, than the offspring of the psychiatric controls. And when Jerry Kagan dichotomized this, there were basically higher rates of behavioral inhibition among the panic disorder offspring. We also, and I say we because I was a research assistant with the study at the time, and I later stayed with it through graduate school and became an investigator. But at this point, what we did was we were able to do clinical interviews on the parents of children in Jerry Kagan's sample. Jerry Kagan had recruited a sample of children from birth records at hospitals whose parents described them as shy. They came into the lab, found out that they were extremely inhibited, and we were able to do diagnostic interviews on their parents. And what we found was that if you look at the second bar, social phobia was significantly elevated in the parents of these children selected on the basis of behavioral inhibition. And when we asked the parents about childhood disorders using diagnostic interviews about childhood disorders administered retrospectively, they had much higher rates of having any anxiety disorder as a child, also of having over-anxious disorder, which is a tendency to worry too much, and having avoidant disorder, which back in DSM-3 was the child version of social phobia. So just to show you what avoidant disorder is, it's excessive shrinking from contact with unfamiliar people for 6 months or longer, sufficiently severe to interfere with social functioning. So it's like generalized social phobia in a child. In addition, BI increased the risk for anxiety disorders in children from both samples. And so these are the two samples combined, the sample thrown together at MGH and the sample recruited by Jerry Kagan. And when you look at what anxiety disorders the inhibited versus non-inhibited children had at baseline, you see that they had significant elevations of the things you would expect, like avoidant disorder, but also of multiple anxiety disorders. And phobic disorders at that point using that instrument could include phobias of social situations. So many of those phobias were things like, I'm afraid to raise my hand in class, I'm afraid to talk to the teacher, that kind of thing. At 3-year follow-up, they also had higher rates of social phobia, of avoidant, but also of separation. But one caveat about all these data is that we didn't covary parental diagnosis, and we know that the children of parents with panic or social phobia were the ones who were more likely to have behavioral inhibition, and now we're saying that the inhibited kids are more likely to have anxiety disorders in general, but we didn't have the power really to covary parental psychopathology. One other thing that we found from looking at those samples is that the children in Jerry Kagan's longitudinal sample who had been consistently inhibited from ages 21 months to 4.5 to 5.5 to 7.5, when we looked at them diagnostically at 7.5, they were the children who had the most anxiety, who had the phobic disorders, and also who had the parents who had had childhood disorders and continuous disorders in childhood and adulthood. So, as I said, these studies were limited by small sample size, by absence of normal controls, and by insufficient power to covary parental psychopathology.